Hey listeners, did you know this episode of med-surg Moments is eligible for CE credit? After you listen to the episode, you may claim 0.5 CE hours by following these easy steps. First, log into the AMSN online library at www.library.amsn.org. Then complete the evaluation for the podcast episode and submit to earn your certificate. The Academy of Medical Surgical Nurses is accredited as a provider of nursing continuing professional development by the American Nurses Credentialing Center's Commission on Accreditation. There are no relevant financial relationships with ineligible companies for anyone with the ability to control the content of this episode to disclose. Enjoy the episode.
Settle up with AMSN this fall by registering for the 2025 AMSN Convention happening September 11 through 13 in Austin, Texas.
You're in for 3 days of medical surgical excitement.
At the convention, you'll join hundreds of like-minded nurses at enriching educational sessions led by over 80 industry speakers, 11 different networking and meetup opportunities, and so much more.
Elevate your medical surgical practice by joining us in Austin for #AMSN 2025.
Register now at amsn.org/events/AMSN Convention. On this episode of med-surg Moments, our topic today is how to encourage patient nutrition.
Here to help us navigate is Dr. Beth Quatrara, an expert in patient digestive health and associated...
I grew up in upstate New York. My mom was a nurse, and so I had the opportunity to watch her, to learn from her. Watching patients having to be NPO for so long was just a real stark reality. When patients are malnourished and undergo surgery, they're more likely, believe it or not, in 2009, the American Society of Anesthesia, what's the best thing med-surg nurses can do is to do with the patients being depleted of energy when we're not feeding them.
The GLP-1 medications are very common today. So what are some of the things that medical surgical nurses must know?
How can we best support our patients on enteral nutrition to ensure that they have the...
If you're a med-surg nurse and an institution hasn't done this yet, this might be something to think about. It's called a...
This is Mary Tess,
Sam,
Eric,
Marcella,
LA.
and Sydney. Welcome to med-surg Moments, the AMSN podcast.
This podcast is an engaging look at the lives of and surrounding medical surgical nurses.
We're proud med-surg nurses just like you, sharing our stories, insights, and experiences to support you in your nursing journey.
Our topic today is how to encourage patient nutrition. Proper patient nutrition is more than a diet, it's a vital sign. From admission to discharge, there are many intentional moments where we can champion patient nutrition at the bedside. Also, as nurses, there's always something we can learn about improving our own nutrition.
here to help us navigate is Dr. Beth Quatrara, an expert in patient digestive health and associated nutritional complexities.
Beth is a doctorally prepared clinical nurse specialist with over 25 years of nursing experience. She presents nationally and publishes on nutrition-related topics, as well as clinically related issues. Presently, she serves as Associate Professor and Program Lead for the MSN and DNP Graduate Program at the University of Virginia School of Nursing. Beth, welcome to med-surg Moments.
Thanks for having me.
As is our tradition with all special guests, we'd like to begin at the beginning. Tell us your story, where you're from, your childhood, and what inspired your journey towards nursing and a focus on nutrition.
I grew up in upstate New York, way upstate New York, almost on the Canadian border. My mom was a nurse, and so I had the opportunity to watch her, to learn from her. I also have to say my own healthcare adventures along the way introduced me to many nurses. I had bumps and bruises and falls over the years. There was many a wonderful nurse there that I met, and just a desire to help others. I obtained my bachelor's degree in upstate New York and then moved to Virginia. After graduating with my master's, took a job with the Digestive Health Center. And that's where I really learned about the importance of nutrition. Not only the impact of what we feed patients and how we feed patients, but also the harsh realities of being NPO. The science clearly tells us that when we don't feed patients, our outcomes aren't as good. Patients are less likely to heal as quickly. But there's such a social component to that as well. I distinctly remember caring for patients with acute severe pancreatitis. And patients who have pancreatitis, the only way to let that pancreas heal is to let it rest. For some patients, that was months of not eating. Every time they would eat and food would pass through that portion of their small intestine, the pancreas would become aggravated. Certainly, we provided nutrition. We bypassed the pancreas with a feeding tube, but these patients for months couldn't put anything in their mouth. That's how we greet people. Come on in, have something to drink, something to eat, or can I meet you somewhere for something to drink or something to eat? We're so socially acclimated to food, to nutrition. And so watching patients having to be NPO for so long was just a real stark reality for me.
I love what you said about the NPO, the social part of nutrition. I always remember not eating is the same as overeating. It's really a bad habit. So I really appreciate the introduction. Can you share with us how can medical surgical nurses promote optimal nutrition and hydration in patients before and after surgery?
As med-surg nurses, we have the opportunity to see many patients before surgery. Many of the surgeries are elective. Certainly there's those who come in through the emergency department and we have no morning and we don't have the opportunity to prepare them as we would like. But the vast majority of patients are elective surgeries, and we have the opportunity to connect with them preoperatively. And I would say one of the most important things we can do there is to screen the patient for malnutrition. It's astounding the number of patients who are malnourished preoperatively. And then we make them NPO for surgery, and we just exacerbate that condition. So anything that we can do to assess these patients early and identify their nutritional needs, the quicker we can intervene. There's many instruments out there, many validated instruments to help us screen our patients. Pick anyone, which one doesn't matter. I will say the MST, or the malnutrition screening tool, is probably the quickest. It's 3 questions and then a quick little math problem and you're done. Pick one that works for you in your facility. It really doesn't matter which one. But when patients are malnourished and undergo surgery, they're more likely to get an infection. They're more likely to have poor wound healing. They're actually more likely to fall. And those are all things that nurses really care about because many of them are tied to nurse-sensitive indicators. Yeah, I think the other thing med-surg nurses can do and are really great at doing is understanding the science and the guidelines behind the care we provide patients. And unfortunately, there are still some protocols sitting out there. The traditional language is NPO after midnight. Believe it or not, in 2009, the American Society of Anesthesia said patients don't have to be NPO after midnight anymore. So that was 2009. More than 15 years ago. Patients can have food up to 6 hours before and clear liquids up to 2 hours before if they're low risk for complications, right? So our healthy patients, our non-pregnant patients, not the pregnancy is not healthy. Pregnancy is a beautiful, healthy state, but it could increase the risk of reflux and therefore aspiration. So as long as our patients are low risk, let's have them eat. And actually, when patients eat and have liquids within that shorter period of time, the outcomes are better. Their post-operative outcomes are better. So what's the best thing med-surg nurses can do is to do what they do every day. Implement the best practices, implement the best sciences, screen our patients, and intervene early.
When you hear patients are on NPO. They're on NPO for days before the surgery. And guess what? I know we all know this. NPO days after the surgery. Like, this is torture. Why do we do this to our patients?
We do. Many of our patients are malnourished going into surgery, or maybe they have an illness that's keeping them from eating prior to surgery. Maybe they have nausea, vomiting, something that's preventing them from eating prior to surgery. And then we operate. And then we keep them NPO for days after while we're waiting for a test or a procedure or maybe even the return of bowel sounds, which again is not current science anymore. The patient's being depleted of energy when we're not feeding them. And yet we're saying, use your incentive spirometer, get out of bed and walk. And yet we're pulling their energy source. So we just have to feed our patients and feed them as soon as possible.
What do you think is making the nurses not do what they have to do? Personally, I see some of them are afraid to ask, or the confidence level of telling the doctor, that's one. So based on your opinion or experience, what do you think are some challenges that we're experiencing, why med-surg nurses are having this challenge of doing the best practice, like you said?
I know that at the end of the day, we all want the best for our patients. Everyone on the team does. Yet we can all point to that one bad outcome, the one patient we fed early who vomited a huge amount, aspirated, developed a significant pneumonia, and perhaps didn't survive. Those type of pieces, those types of stories get passed. And we all should be afraid of those events. We need to be mindful of those events. We equally need to screen our patients for aspiration and place our patients on aspiration precautions as appropriate. So I think it's really looking at the data to say, okay, yes, we had that one patient and that was terrible. But since then, we've put aspiration precautions in place and we have new screening practices. And that was 1 out of 1,000. So why are we depleting these other patients for that one event? I think data is always helpful. And then pulling current guidelines and policies. It's hard to stay up on the policies. A quote I've heard is that you need to read 17 journals every day to stay up to date with the science. None of us can do that. We need to team up and we need to help each other by pulling current guidelines, pulling current practices and sharing them with one another so that we can elevate everybody's practice.
That's awesome. Awesome, Beth. So I have a question kind of related into sharing practices and everyone staying up on knowledge. The GLP-1 medications. These are these medications that a lot of patients are starting to use often. They're used for diabetes, but a lot of patients I see that come into my hospital setting and my unit, they're trying to lose weight. They are trying everything they can try besides the right way of losing weight. The GLP-1 medications are very common today. So what are some of the things that medical surgical nurses must know about caring for the patients that are taking these medications?
Wow, those GLP-1s, they are here to stay and they are expanding in their scope. The GLP-1s initially came to the market as a diabetic medication. They are known to increase insulin secretion. They also help with stomach emptying and suppressing glucagon release so that we're not using other sources to build energy or to create energy. But since that time, they've expanded to help with managing obesity. I was just reading today that there are some uses for it in terms of managing liver disease as well. So I think we're going to continue to hear more and more about the use of GLP-1s. I think it's important for nurses to know, as we would with any medication, why is the patient taking it? And I think that's important to know because that helps us to understand whether or not we can hold the medication for the patient. So understanding why the patient's on the GLP-1 helps us to understand how to manage the patient who's taking the medication. So if the patient is taking the medication for a diabetic source and we're holding that medication for a particular reason, we need to think about how are we otherwise going to supplement their insulin. If we're holding it for weight management purposes, they're probably okay for a few days to not have it. So number one, understanding why that patient is on it is so important. Also, understanding the side effect profile, I think, is really important. These side effects are relatively common in patients who take the medication. Some of those side effects are nausea, vomiting, diarrhea, constipation, bloating, and a decrease in appetite. And we've been talking about the importance of nutrition and eating well when you're in the hospital. And yet, if a patient is taking a GLP-1 and experiencing some of these side effects, again, if it's not for diabetic purposes and or if we can get them off of it and increase their insulin dose for a time period, perhaps we can manage some of these symptoms and get them over a little bit of a hurdle. It's also important to understand these side effects because if a patient is being treated for a condition related to any of these, we need to know that the condition is being exacerbated by this. I was talking about patients with acute pancreatitis a little bit ago. So let's go back to that one. Pancreatitis is known to be associated with nausea and vomiting. So if the patient's on a GLP-1 as well, maybe we take it off so the patient can feel a little bit better and we have a better sense of how they're progressing. It's really important to understand the medication and its side effects so we can separate out what's a current illness and what might be a side effect from this medication. And again, we want our patients eating. Nutrition is so important. And so to be thinking about these medications and patients' appetite and patients' nutritional level, not just from a weight management perspective, but from a true nutritional perspective. Are they getting the micronutrients that they need? Not just the protein, the carbohydrates in sort of the grander sense, but are they getting the micronutrients they need? Our registered dietitians are our friends. We can always call them to help. And our pharmacists as well, as we're managing these medications and helping determine what substitute medications might we be able to put in place.
Yeah, those GLP-1 medications, I've seen them do incredible things, but I know that the hot topic is, are we overusing it for the wrong reasons? You kind of have to catch yourself sometimes saying the right way to lose weight. We all know exactly what you're talking about, the long-term physical diet restrictions, but the things I've seen it do for A1C, bringing it down for people, there's always a best practice, there's a best way, but this person losing time, the idea that you can kind of skip ahead a little bit on bringing down your A1C, losing weight, and then have the energy to start doing physical things. It seems like an exciting prospect, but of course, just with everything, the over-prescribing or side effects, it's incredible how it brings down people's appetite. They're losing weight because of the medication, but then they forget to eat at all. Bowel obstruction is super common because then they're not eating or they're not feeling well and they're not moving. And that's super common. So then they don't want to eat or drink at all because they're nauseous. So they're kind of stuck in a loop of side effects and then they're losing weight at the same time. So they're not going to heal the same way. So it's great to keep talking about it. I think anytime they're admitted to just review, even if they've been on that kind of medication for a while, to review those side effects and recommendations and get you, the nutritionists, on board, even if their state isn't related to that, because the reminder of how to take care of themselves while on that is super important.
There are some biases out there about GLP-1s. With everything in life, we all come to the table with our own perspectives. And it is so important to remember that weight loss leads to a healthier person. We want everyone to be healthy. And in diabetic patients, absolutely, if we can drop that hemoglobin A1C and reduce the risk of cardiovascular disease, reduce renal injury, all of those complications, that's fantastic. Also to remember, all of us have GLP-1. It's an incretin that we all have, and these patients are just taking an agonist. They're taking essentially a little bit more than maybe some others, but all of us have GLP-1.
We're going to pause for a quick moment to tell you about a special AMSN membership offer just for you through the end of this month.
Hey, med-surg Moments listeners.
We have an exclusive offer for you.
When you join AMSN by June 30th, 2025, using the code AMSNPOD,
You will receive $5 off your membership.
Visit amsn.org/join and be sure to enter AMSN-POD when you check out.
Okay, we're back. Kind of going back to a little bit of the NPO topic, patients on tube feedings. How can we best support our patients on enteral nutrition to ensure that they have the adequate nutrition as well?
We know the gut is best. We were made to eat that way. We were made, actually, quite frankly, to be bolus feeders. We take a chunk of food at breakfast, at lunch, and at dinner, And so we want, for the most part, our patients to have that same experience. In the ideal situation, a patient is getting tube feeding and we're feeding into their gut, and we would do it by a bolus, breakfast, lunch, and dinner. But unfortunately, a lot of our patients can't tolerate that amount of feeding at once. Maybe the tube's not in the stomach. Maybe we can't feed their stomach. Maybe we have to feed smaller into the intestine, and our intestines weren't made for the bolus feeding that our stomach was made for. And so when we feed our patients tube feeding, we are typically feeding them small amounts over a longer period of time. Some patients are getting it 24 hours a day. Some patients maybe 18 hours a day. But whatever length of time the patients are getting their nutrition, it's important they get it. It's a prescription. It is a very well thought out, calculated order that we're running for our patients. And so when we're giving our patients tube feeding, we want to make sure they get all of it. If they've been ordered breakfast, lunch, and dinner, we want them to have breakfast, lunch, and dinner, not just breakfast and lunch. And so when we're tube feeding our patients, it's important that they get every bit of that formula that's ordered for them. Now, the reality is, and we all know this, that for a number of reasons, it's really hard, especially if the patient is supposed to be getting tube feeding 24 hours a day, to have that tube attached to that patient 24 hours a day. The patient was got a lot of IV poles as well, and then there's the tube feeding pump attached. Physical therapy wants to ambulate the patient, and yet they don't have enough arms to help the patient, the 6 IV poles in the tube feeding pole. And so they asked for something to be disconnected. Can you disconnect the tube feeding? And the reality is, can we disconnect a tube feeding for a little bit and have that patient be okay? Sure, we can. Sometimes the patient going for a procedure as well. Transportation wants it disconnected, or maybe for the purposes of the procedure itself, it needs to be disconnected. And so we can go ahead and do that. But again, we want that patient to get essentially the 3 meals a day. So how do we then catch up those hours which the patient wasn't connected to that feeding? A practice that a lot of institutions have picked up, and if you're a med-surg nurse and an institution hasn't done this yet, this might be something to think about, is called a volume-based tube feeding protocol. So essentially, you would get an order for, let's say, 1,000 milliliters of tube feeding over 24 hours. You would then have a chart that calculates out that rate. But if your patient is disconnected at multiple times throughout the day, you only have 12 hours to run that 1,000 milliliters. You got to pick up the pace. You got to run it essentially at double time. That's what volume-based feeding does. It allows the med-surg nurse the flexibility, the autonomy to recalculate the rate so that the patient gets the feeding that they need every day. Nurses are smart. They can do the math. They know how to feed the patient. And as long as the patient's tolerating it without any nausea, vomiting, bloating, it's safe for the patient. And it guarantees that patient gets the full meal, gets the full nutrition, and gets the energy they need to heal, to recover, and to get home. Because as awesome as we are as med-surg nurses, patients don't want to hang out with us. They want to get home.
And side note on the tube feeds, something that always comes up and people have different ideas about it, but free water flushes. I feel like sometimes there's nothing and sometimes there's 400 every 4 hours. And I'm like, that seems pretty important. What are your thoughts on that?
Yeah. Patients receiving tube feeding need some water to keep the tube from clogging. So a vigorous flush essentially rinses out that tube and prevents formula particles from adhering to the inside of the tube and reduces the risk of clogging. How much water a patient gets throughout the day depends on the patient. Some patients are able to sip on water, whatever their health condition is such that they can sip on water. Let's say it's somebody who's anorexic. We're giving them tube feeding to help increase calories, nutrition. They can eat around that tube. They can drink water around that tube, and that's fine. However, we have somebody with kidney failure. That's a different story. We may be wanting to hold back some water. So for every patient, those water requirements are going to be a little bit different, but at a minimum, everyone needs some degree of water.
Thank you. And then just one more note on the people who are NPO or not, and we're trying to get them to eat. I think a lot of nurses forget that oral hygiene is such a big booster for them to even think about food. And it's so easy to forget because we're like, okay, our PCT should be doing this, or a family member's there. Surely they're offering to help them with brushing their teeth. And then you hear them say something terrible like, I haven't brushed my teeth in 2 weeks. No one's asked me to do that. Is that pretty common? Do you see that?
Not as much as we used to. And, I think to your point, we've all become a little bit more aware of the importance of oral care. But oh my gosh, that's important, right? The brushing the teeth allows us to actually taste food. Remember, patients with just real thick layers of thrush and other, let's just call it guck, on their tongue. And that when you can actually brush that off, clean that off for them, oh my gosh, now they can eat again because they can taste. To have that normal feel, that sensation, you feel human again. You feel well again.
I wanted to add one thing about the enteral feedings real quick before we move on. We're actually implementing new pumps at my hospital for our patients receiving enteral feeds, and it will actually keep track of how long the feeds have been interrupted and give you a volume of that, like how long it was paused. And I think that's a really cool way that we can leverage technology, again, to kind of use that practice that you were talking about, giving nurses a little bit more autonomy to ensure that the patient's actually getting their full prescribed volume, even if we do need to pause it intermittently throughout the day. So it's kind of cool. I feel like we're getting into the 2020s here with these pumps. It's very exciting.
That's fantastic. The more that we can use technology to help us, we don't have to sit there and do the math on the back of a glove anymore.
Yes, absolutely. So let's switch gears a little bit here. But with medical surgical nurses working really long shifts on day shift, night shift, weekends, what are some ways that the nurses themselves can lead healthier lives?
That's tough for all of us. And as much as we talk to our patients about it, sometimes it's hard for us to walk that walk ourselves. It's easy to grab the ultra-processed meal, pop it in a microwave, and go ahead and eat it. Yet we know that current science is showing us that those ultra-processed foods are so unhealthy for us. They've been associated with cardiovascular disease, hypertension, a host of cancers. And so we really want to avoid that. So what can we do? Meal prepping at the beginning of the week. Go to the store, buy some fresh fruits and vegetables and chop them up and prep them in different containers. Cook up some good brown rice. Put some proteins aside, whether that's beans or lean meat, but sort of pre-package and pre-prep those foods on your days off. Then when you just need to grab something quick because you're exhausted and you're needing to run out the door, that you have something ready to go. I think along that path, we also need to think about the newer USDA food plate that's out. If you look at the plate, it's increased the size of vegetables and increased the size of whole grains, reducing fruits and reducing protein. So again, those whole grains are something that maybe we don't necessarily think about as much, but to be thinking about those as we're at the store or running through the cafeteria line, to think about grabbing some of those and adding them to a plate that's plentiful in vegetables. Another good rule of thumb is color. Just a bright, colorful plate is usually a healthier plate. So think about the green, orange, red, purple looking plate.
I love that tip on color. I'm so bad at remembering portions and grains. I'm like, what? I like the color trick. That's going to help me just visually check.
Yeah, right. Look at your plate and think, well, what's another color I could add? How can I pretty this up?
I love rice, tons of rice. I have a colleague and she would always say, there's no color in your rice. And I said, okay, I'll make brown rice tomorrow. But it's a good tip. Yeah, I agree with you, Marcella. It works for me because I'm really working hard to eat veggies, but I'm getting there. I love your tip about when you're exhausted, you want to grab something, just to have rice and beans, easy, quick, something that you really can do as nurses. I love the rice and the beans, and then just add something.
Yeah. If you throw a few splashes of color on top of that rice and beans and you're all set.
Do you have any dietary recommendations that are different between people that work day shift and night shift? So I know when I was working night shift, I feel like I would eat so differently than when I was on day shift because I just wouldn't want to eat a salad at 2 a.m.
Right. Our acid levels change at different times of the day. people who work night shift are looking for something that's maybe a little bit calmer on their stomach. So I was going to say, if you're working night shift, maybe have that salad before you go out the door. And then at night, think about maybe that sort of breakfasty kind of thing. So maybe some oats with some berries on it, a few nuts, and you could have a very healthy dinner that maybe looks a little bit more like breakfast.
That's a great recommendation. Well, believe it or not, we're actually out of time. Beth, it's truly been an inspiration, an honor, and a pleasure having you on this episode of med-surg Moments.
Thanks so much. I enjoyed talking with all of you.
And to our listeners, thanks for joining us. We'll see you next time.
We look forward to connecting with you on the next episode of med-surg Moments, the AMSN podcast.
In the meantime, we encourage you to subscribe to med-surg Moments wherever you listen to podcasts.
To reach us, use hashtag med-surg-moments on your social posts.
Or send us an email at amsnpod@amsn.org. That's amsnpod@amsn.org.
We are all AMSN members, and if you love med-surg Moments, we invite you to become a member of AMSN. You can learn more at www.amsn.org.
Finally, the content within the med-surg Moments podcast represent the views, thoughts, and opinions of the co-hosts and may not necessarily reflect the views, thoughts, and opinions of the Academy of Medical Surgical Nurses.
Until next time, this is Eric,
Mary Tess,
Sam.
Calais.
Marcella.
And Sydney. And always remember, med-surg Moments is a moment in our lives and a moment in our med-surg careers that makes a huge difference.